Good afternoon, friends. I'm audible. So, welcome to yet another session on mini conference which we are conducting every month with Empire and IMA Chennai Metro. So, I welcome all of you. Mr. Shankarlingam is an observer who has come from Tamil Nadu Medical Council. We welcome you, sir. And this is a cancer awareness month. Normally this month we have cancer awareness which is being conducted in a big way in cancer hospital. So we thought we'll have one more session exclusive for cancer for general practitioners. So I requested all the speakers, in fact all of them are from Vinitha Hospital. I requested them to give it in such a way that it is interesting for general practitioners. Actually the whole lot of them are general practitioners. So we do not want high stars, because normally if cancer comes we refer it off. We don't keep it to them, but at least you must know how to diagnose, when to diagnose, what are the symptoms for cancer, and what are the available modalities for treatment. This is what we do. So you want to restrict yourself to, in fact I told Shiva also about it, so we will restrict to whatever is essential for GPs. What are the symptoms we have to look for around that. So with this introduction, we will start off the first speaker. Before that, we will just hand over a membership certificate to one of the delegate here. I request the President to come and hand over Dr. Mangair Karasi. Where is Mangair Karasi? Please come. So we won't go on without wasting much of time. We'll go on to the first speaker. May I request Dr. Subhashini to introduce the first speaker.
Good afternoon. I invited Dr. Sarita to deliver a lecture on common cancers in general practice. She is a senior consultant, radiation therapy and clinical oncologist at Venkataeswara Hospital, Chennai. And she is a secretary for Association of Radiation Oncologists in India. That is Damodaran and Puducherry chapter. She has done MD from Cancer Institute area and also the PG diploma in medicine from Cancer Institute area. She did her MBBS at RG Kar Medical College. She is specialized in brachytherapy, precision radiation therapy techniques including IMRT, IGRT, BMAT, rapid arc, SRS, SRT, pain and palliative care, preventive oncology and cancer screening including breast clinic. And she has received an award for the best paper in Association of Radiation and Oncologists of India. With this introduction, I invite Dr. Sarita to deliver the lecture. Thank you.
Thank you for this wonderful introduction, ma'am. Considering that all of you are very much my seniors, I seek your blessings and I hope I stick to the point and as sir has requested, and start off with my talk. I was given this topic, common cancers and how do we deal with it every day in our practice. Invariably, an orthopedician might get somebody with back pain. Because recently, I do have to tell some small anecdotes, only then it kind of registers in our mind. There was a patient for the last 6 months who's been having a back pain, low back pain, difficulty in walking. He's been consulting an orthopedician. So the evaluation has been done pertaining only to the back pain. So we do, as usual, we take an X-ray, we ask for an MRI, and we prescribe some medications, and there are some litigation, some issues there. So we're wondering whether the orthopedician is wondering whether should we do something more, some more evaluation or what. So this is the kind of time, if we are all there, available at a hospital under one roof, it is extremely easy. But as we all know, it is not like that for everybody. So that was the scenario where I come in, and this patient situation was discussed in over the phone. And then I said, why don't you just, when you're screening, they said, should I check something in the chest or should I go for a PET? We feel the PET. So right away, the thinking about a PET scan doesn't sometimes really yield results. But in this case, luckily it did. We found a small lesion which is just about some 4 millimeter in size, which had a metabolic uptake, but then nothing. But his vertebra was studded with metastasis. So a small lung lesion, straight away going to stage 4. So this was the scenario. So with this background, this is something which we do see. Nothing wrong in what the orthopedician did. He was very right in whatever he had advised. But there is a possibility that we miss. So we can't ask every time. A chest X-ray might not have yielded this 4 millimeter lesion.
Madam, are you suggesting that you should not do a PET without confirming the lesion?
Usually that is how it is, sir.
No, because 4 days before I had a case with the lesion in the lung, which was very inaccessible. I didn't know what to do, but I want to know whether it's, so I did a PET. PET showed metabolic
uptake.
So that could confirm the.
Sir, there is no hard and fast. PET scan, MRI scan, all these are for our benefit to help and identify what the problem is. As long as we and the patient are on the same page, there is no issue. வெளியில வந்து அந்த டாக்டர் என்னெல்லாமோ எழுதி கொடுக்குறாரு, அந்த அந்த இடம் மட்டும்தான் நம்ம we have to be careful. Otherwise, there is no hard and fast rule, because sometimes even tuberculosis, extensive tuberculosis picked up, arthritis picked up. It's very sad that arthritis has to be picked by a PET, but then it has showed that it is definitely not malignancy, and it is definitely some inflammatory thing, because all inflammatory diseases also are picked up by PET scan. There's a lot to talk on PET scans, but I have been given one topic, so I will stick to that. Yes. So in our Indian scenario, there are more than 100 types of cancers that we see. Everywhere except everybody knows the nail and the hair. Everywhere else we have cancer. 5 most frequent cancers that we see is breast and oral cavity, cervical cancer, and also nowadays the uterine cancer. It's not being studied, it's coming out. The studies are being done, but uterine cancer is another one. Lung and colorectal. These are the overall.
Which is more, the uterine cancer or breast cancer?
Breast.
But why any specific reason?
Yes, sir. As I go about that, that's the topic I've been given. Actually, I finished making within 5 slides, everything was over. Then I thought the best is, as we discuss, I welcome anybody to interrupt, and you can ask, because that is the only way. Otherwise, there's no meaning on a Sunday afternoon for all of you to come here, take time out. So I am willing to discuss on whatever is queries on the mind. But the next thing is, second most common cause of death is cancer. After heart, definitely. So.
No, ma'am. Second most is strokes.
Strokes, sir.
Third is COPD, my department.
Your department.
Fourth only is yours.
So we will jump and come, sir. Because we, by 2025, we have been projected as one big.
Actually, COPD and cancers are fighting.
Actually, with COVID also coming into the scenario now, the lung scenario is very difficult. Many malignancies we are missing, the lung cancers, because of that. Anyway, so this is what we've been told. Tobacco, smokeless, smoking, everything is there. Tobacco, all of us know. More women in India are dying from cervical cancer in our country. But of course, our cervical cancer has gone down now. The breast cancer has come up. And breast cancer, most common cancer in Indian women. There is, you go this way or you go that way. Anyway, I searched today in all the WHO and other sites also, because I thought when I'm coming and presenting some facts, let me read up about it. And I found one thing, there is no change. Breast cancer is the leading cause of death in women in our country, and it is the leading cause of cancer.
They say suckling will reduce breast cancer. If you suckle the child, the breast cancer is less. In India,
she's come back in just
yes, sir. So
I was under the impression, because only in India women suckle the child.
Okay.
But abroad they don't.
Okay.
So but I thought it should be more there.
Not really, sir. It's not so. And yes, endorphins, a good amount of hormones are secreted when a baby is fed. But today's Indian women also have moved into pumping. So there is a lot of change in women's lifestyle, in an Indian women's lifestyle. So that might also be the cause. We don't know. All these things are a big thing for research by the epidemiologist and all that. But there is a big lifestyle change in the Indian women also. About 3/4 of all the cancers, is modifiable risk factors. Your lifestyle. That was what is very sad. Most of it is can be prevented. Cancer is a major health prevalence in our country. The major public health prevalence is breast, oral, cervical, lung, colorectal. If we detect it early, there is an extremely good scope of cure and longevity in these patients. So it is not that cancer, that's the end of story. So cancer screening saves lives. I have a couple of my other colleagues also to talk. So we will be talking about the screening and all that. Though I run a lot of breast clinics and do a lot of screening and attend a lot of camps. But now world, if you look at in the world, we should know what is the international cancers also. So be it male or female, any age, it still is, breast is the leading cause of incidence, almost at par with lung. The incidence of breast and lung cancer is at par. But when you look at mortality, it is the lung cancer which is going high. And so this is it. Breast cancer, the prevalence is more. When we look at just women, when we look at women, the incidence and the prevalence is more for breast only. And then comes colorectal and lung. This is worldwide. We are not talking about India or Asia. This is worldwide. We should know that the uterine cervix and all is a little less. So this is world. In male, all ages, men, we have the prevalence of prostate cancer very high. The prevalence is high, but the mortality is not so much as lung. Because it's an indolent disease, it takes a long time to surface, and whenever it surfaces, we can treat it, it's curable. It's a long-standing process there. But lung, the mortality is quick. The prevalence is, and then colorectal is the other. Coming to India, this is the scenario. We do have the breast cancer somewhere, and we are having colorectal and lung and cervix uteri has come down. So somewhere when we look at it, after the breast comes the lung cancer, uterine cervix and rectal cancers are somewhere similar. And then comes all the other cancers. When we look at the men, in our thing we have to add something new, lip oral cavity. That is taking the highest, purely because of tobacco and also because of repeated inflammatory issues, maybe because of sharp tooth, all that. So, because I have patients that is even difficult to treat, who are non-tobacco chewers who are having oral cancers. Theirs is even more difficult to treat actually. Lung is the other, and stomach. So this is how it goes. Though the rectal cancer, the prevalence is a little higher on the higher side. Coming to the new cases, when we look at Asia and world, and both sexes and all ages, when you look at it on the whole, lung, breast cancers cover a huge portion of that pie chart, and then comes the colorectal and the other cancers, all in a small part. So some of the very, very preventable and very obvious causes are obesity, infection, alcohol, environment. Okay. So we do see a lot of
Smoking, madam.
Sir?
What about smoking?
Sir, all that is preventable thing. I was talking about some of the most common, very common scenario, because today I don't know how many of you might have noticed the younger generation are definitely obese.
Yes.
Today I've been going on and off to many colleges and I do see a lot of children who are really obese. The age group between 17 to 25, I find them definitely on the obese category.
The elderly are not obese.
The elderly are not so, sir. Not so. When you look at, there's actually an Independence Day celebration, I went, and that was a march past by the college. I don't want to mention the college for all privacy. It was very pathetic watching, because I found everybody fitted into the obese scale. All the children. There were some, it's a college of 100, it's a medical college. The medical college, 150 students, and there were a 50-50-50 batch, except I think some 10 were on the NCC. The rest of them were doing the march past. It was very pathetic to note that they are on the obese side and being in a medical college. And I did mention it there and then. They have to do something about that. So this is a scene which we might not find right away. Next door you find it. Maybe relative's kid is obese. You do, but then you do find obese kids nowadays. Inactive children. So, in Asian, this obesity leads to what all kind of cancers? What are all the common cancers we see? You see corpus uterus, uterine cancer. Here we see. Now, when will that manifest? When that person reaches a particular postmenopausal state, 50, 60, whatever. That age it might manifest. Breast, postmenopausal again, colon cancer. The others are not very significant. So obesity has a higher ratio to this uterine cancer. Obesity in Asian countries. Somehow China is leading. I was very happy. China is leading. Japan, I was very surprised to see. Actually, this entire work today, it was a lot of enlightenment for me, because Japan is one country I really appreciate for a lot of things that they do. Be it stomach cancer, they are the leading people, pioneers, whether it is the surgery. No, all of us look at West for all the NCCN guidelines and all that. But for stomach cancer, we all turn towards Japan, because they have the highest number. Whatever is their problem, they try to solve it. That's their attitude. They have an excellent attitude. So I was surprised that they are the second, but 13%, and we are not far. We are 6%. India is 6%. China is 45%. So that's for consolation.
Prosperity is causing.
Prosperity, the number I don't know, sir. Prosperity, sir. Yeah, we are people who, many of us don't get a square meal of food in many parts of our country still. So infections is another very important thing. As general practitioners, I think that will interest you all, because vaccinations are there in each and every be it pediatric group or be it a gastroenterologist or gynecologist. A lot of vaccines available to prevent. So Helicobacter pylori, HPV, hepatitis B virus, C virus. All these infectious agents do contribute, be it to the cervical cancer or to some of the pharyngeal oropharyngeal cancers, HPV.
What is the vaccine for Helicobacter?
No vaccine.
No, that's it. There is no vaccine.
Yeah, that's the problem.
We just treat, but we know. When we do the endoscopy, we know, so we can treat. It's a treatable. What I'm talking about is all preventable stuff. which we see.
pylori is caused by the kind of food that we eat.
Meat, yes.
Is it the outside, I mean the uncooked food or the...
Ma'am, actually, I will talk like a layman here. What I felt pertaining to myself, when you secrete a lot of gastric juice, our good enzymes die. Whatever anybody says, I'm sure I'm in presence of eminent gastroenterologists, etc. But I tell you, when an acid is secreted, definitely our good enzymes are going to die. So when our good enzymes are going to die, where is the question of good digestion? It is going to be gastritis. Gastritis, acidity, ulceration, inflammation, ulceration, etc. leads to erosion and finally cancer. So we have it. It is something very curable. All you need is 14 days of medication or whatever. It's very simple. The other one, HPV, just vaccines are available. Yeah, be at the gynecological center. Even for men, they are recommending. Yes. So, and very soon it will be incorporated by the immunization programs for children too. So that we needn't worry, but at least for the older age group, it might be useful. Hepatitis B also, all of us, in the medical community, it might not be of importance, and for the younger generation, it is not a problem because it is all there in the immunization schedule. We don't have to worry. It is the interim group which is missed. That unless and until as a family physician, when they come to us and when we talk, we can enlighten them maybe about these vaccinations.
Because most of the gynecologists are frightened young girls saying that if the family is to breast cancer, you will also get it. Mother, you will get it.
Yes, sir. So, my colleagues are waiting actually. They will throw some light on those points because it is like this: 50 years and younger women, a mother gets breast cancer. There is a chance, but it is not necessary that all the suppose the mother has given birth to 5 children, all the 5 children are going to get. No, there is a 1% chance.
So it's not hereditary.
There are hereditary cancers, which is also identifiable. There are some tests for that. There are some genetic screenings available for that. I think few of this Shiva, you're going to talk on. Who's going to talk on that? BRCA and all that. We don't have that. Now to last penna solidலாம். So hepatitis C virus. So all these vaccines are available easily. We can prevent. Actually, my interest is preventive oncology. So it's nice to talk about it. Income group is again I found very well associated with the infections. It's very clear who are the best people who don't get anything is a low income. The worst are upper middle income. This is what I learned. It is something which we know, but when it is put in a pie chart and it has been checked, this has been taken from the World Health Organization.
Will come in that group, is it?
Yes, sir. I think we all come on that. Yes, sir. In the low income level, I do. we sometimes we are not using mask, and we are exposed to everything. And I don't think doctors now only have. We don't fall in this. We are low income, sir.
Low income.
So this is how it is. So the alcohol. This is again another preventive thing. Oral cavity, esophagus, and pharynx. All this. This is Indian data. This is an Indian data. All these what I showed are Indian data. So oral cavity cancers are more prevalent, along with esophagus, obvious reasons. Alcohol drinking. So where do we stand? India, where do we stand? China is again high here. India is about 8.4. The country which I expected would be high was United States of America. I don't know, somehow they are just 7%. So they are very less.
India is only 8%.
Madam. India is UV radiation, again this was a revelation. because I thought Australians go for the sunbathing and all that, and whenever we have seen a lot of skin cancers is from Australia. But again, a big revelation that it is only 6.8% Australia. India is nowhere there. India is not there in the scene, but United States of America is 36%. High skin cancers are there. This is just to show some time back in Chennai metropolitan what is the highest. This is a very old data, but it still holds very good, and it is true. But the breast cancer, when it superseded, we were all very excited. Then we realized, oh my God, where did we get into? Because cervix was easy. Gynecologist will find out, we could treat, it was all good. Now this breast is, they're all confused. Whom do we go and meet? And people don't realize which is a malignant lesion, which is a benign lesion. Be it common men or be it even medical professionals. So we see a fibroadenoma also, it is operated. I sincerely feel fibroadenomas can be left alone, because once we operate, what happens is, again there is a blood flow, there is a vascularity. Next time we take a mammogram, again same scenario. There is something suspicious sitting there, the radiologist will start. The BRADS 4, madam, till you prove it, we cannot say. So then again the surgeon has to go in to do a biopsy and come. So fibroadenomas, if we know they are fibroadenomas, best to leave it alone unless and until they are giant fibroadenomas. Otherwise, we can leave it alone. Fibrocystic diseases also are very curable. I would always say, half an hour of counseling with a patient. Find out all their dietary, change their dietary methodology, some prescriptions, a lot of mental satisfactions. Patient is fine. And most of the diabetic patients have this fibrocystic diseases. That's something I have also noticed. Because of maybe not taking sufficient antioxidants, nutritional issues, either because avoiding fruits, all these things. So, yeah, this was the slide. Now, prognosis. It's as an oncologist, an extremely important fact lay with what is the initial diagnosis. How are we diagnosing the patient? Somebody comes to us, how are we diagnosing? Are we doing a fine needle aspiration cytology? Are we doing a Druckert biopsy? Or are we going and doing an excision biopsy in case of a breast? So the management is what matters. I think our surgeon will talk something more about all that. But what I'm trying to say is that accurate diagnosis without spoiling the issues as such, the other issues of the patient, will give a good chance for the patient to live longer. So accurate disease staging, that will help early initiation of appropriate therapy. There is a small magic number for CA cervix of 56 days treatment, 65 days treatment. The patient undergoes radiation, completes the brachytherapy. There's a time frame, there's a timetable. He or she finishes that, definitely the survival is better. Compared to the delay, the going around and all that, if that is avoided, it changes the prognosis for the patient. So again, that is one thing, who the patient meets, that is what mainly determines their longevity, how it is handled. So that is why this initial diagnosis is very important. So that improves the outcome, it improves the prognostic stratification and also reduces the patient's morbidity. Defining the tumor biology. Nowadays, we are seeing even carcinoma cervix, which 5 years back, be it stage 2 or 3 or even 4, we used to have a good cure. Unfortunately, now I am even seeing stage 2 and 1 also having recurrence. There is an aggressive element which is present. So there is some change probably in our dietary, I am not sure. All this research is beyond our means. I'm sure there is a scientific community sitting and doing it, but till we get data from them, there is, I want to warn all of you that there is a change in the tumor biology. There is an aggressive element. So we have become even more cautious and we have started profiling, doing molecular studies on small things. And sometimes we feel, why are we doing all this? But it is better to know the prognostic markers beforehand, before we get into the treatment aspects. So because there is something called targeted therapies, etc., which my colleagues will again explain, that it is simpler, it is easy. So the diagnosis aspect is very, very, very important, because first time when they take the biopsy and send it for all these things, the tissue diagnosis should be sufficient material, otherwise it will come back from our pathologist colleagues, inadequate material. Please ma'am, repeat the biopsy. So this is, because there might not be any, especially in cervix, we take once, we take twice. If it is a stage 1 disease or stage 2 disease, we can't keep on taking, because that is stage 1 and 2 only. But so these are what matters. So directing all these newer therapies, etc., it will be easy if the initial thing is very simple and correctly done. Next is early therapeutic assessment. How well have they done? So we have a patient coming, younger age group, older age group, what is the stage, what is the diagnosis, once a diagnosis, then the treatment modalities, how it goes. We have all three of us here because we have to talk about all three aspects. Medical oncology, that is about chemotherapy, hormonal therapy and targeted therapy. A surgeon who will talk about what is more special in the surgical skills that he can offer a patient by removing the nodules, etc. It is not something which everybody can do. He has been trained specially for that. And a radiation oncologist who knows only to switch on a button. Because I hear many of my patients who come and tell, current wake up around the very sad word that is current term. It is not current kadirveechi. என்னால முடிஞ்ச அளவு எல்லா இடத்துலயுமே அதை நான் கிளியர் பண்ண பாக்குறேன். கதிர்வீச்சு அப்படின்ற வைத்திய முறை இது அப்படின்னு சொல்லிட்டு. So கதிர்வீச்சு is radiation, but current வைக்கிறதுனா everybody says.
It's a new therapy.
ஆமாங்க சார், அது இன்னும் நல்லா இருக்கு ஆக்சுவலி. அப்படியா மேடம், அப்ப கரண்ட் வைக்க மாட்டீங்களா? இல்ல கரண்ட் எல்லாம் வேற இடத்துல வைப்பாங்க, அது ஃபயரெல்லாம் தலைக்கு, நாங்க வந்து கதிர்வீச்சு தான் வைக்கிறோம் அப்படின்ட்டு டீடைல். So assessing, tailoring, customizing the treatment, this will help in lowering the cost, because nowadays the biggest challenge is the cost of treatment, because every molecular, as you know, molecular oncology is a vast big ocean, gene profiling, extra, all these investigations itself is expensive. So of course, as time comes, as time goes, all the cost might come down, but till that time we need to be cost effective, so that will help. Post treatment disease surveillance, this is an extremely important thing. Everybody tells me, என்ன மேடம் உங்க ஓபி இப்படி இருக்கு, காலையில வந்து அப்படி முடிஞ்ச பேஷண்ட் ட்ரீட்மெண்ட் ஆனது அவங்களுக்கு தான் முடிஞ்சு போச்சுல, இப்ப என்னைய பாருங்க அப்படின்னு. But the thing is, the follow up is very, very important. Earlier we pick up the recurrence, it is extremely again easier to cure that. Even if there's a recurrence, it is sometimes very curable. So follow-up is also extremely important, but many of our people in our community, in our Chennai itself, we don't want, யாருக்கும் தெரிய வேணாம்னு நினைச்சோம். அதனால நாங்கள் இப்படி குவைட்டாக அந்த ப்ரைவேட் ஹாஸ்பிட்டலாக வந்தோம். இப்போ ட்ரீட்மெண்ட் முடிஞ்சாச்சு, இப்போ உங்களை பார்க்கறது அவசியமா? It is like very sad, but we have to tell them, அதான் ப்ரைவேட்ல வந்துட்டீங்கல்ல, நான் ப்ரைவேட்ல தானே உட்காந்துருக்கேன், வாங்க வந்து பார்த்துட்டு போங்க அப்படின்னு சொல்லி அனுப்ப வேண்டியதா இருக்கு. But there is that stigma. The stigma of cancer is still there in this society. So multimodality therapy is the standard of care. This is the big message that I want to drive across, because it is curable unless and until all the three aspects of the treatment join hands and take a patient, definitely then only the cure is possible. So yeah, this is thanks to him. Since I am basically a radiation oncologist, I just thought small things I will touch upon. PET-CT is one investigation everybody ends up writing. So where all we are doing it in staging and restaging disease. So sometimes when a patient comes in to us, people the patient will come with a PET scan. Yes. So most of the time, so where all it is indicated is in all these cancers, it is definitely indicated, even in breast and thyroid cancer. But in 2020, scenario changed. we didn't want patient to come out for many investigations. So we said, நீங்க போங்க நேரா போங்க PET scan மட்டும் பண்ணிட்டு வாட்ஸ்அப்ல ரிப்போர்ட் அனுப்புங்க நாங்க பார்த்துக்குவோம். It became that way. So now some of the patients say adanna madam romba because the cost is now only 10,000 for the PET scan across all centers.
Where is it getting 10,000?
Everywhere, my sir. So it's a simple thing. Bone scan early, especially in any kind of myelomas or any kind of lung cancer with bone metastasis, earlier pickup is there in the bone scan. So when it is done and when they come, especially now the first incident that I explained, the lung cancer man who came with a back pain. So in such scenarios, yes, this goes a long way. A breast tumor in a PET scan looks like this. We do an MRI for some of the breast tumors. It looks like this. Why I am showing all these images is to go to my part, which is radiation. So ionizing radiation, electromagnetic, it's X-rays that we are using for treatment, therapeutic. Particulate, we do have electron, neutron, proton. See, they will bring, everything is there. It has been there for many years. Carbon, we have not discovered anything new. But missions and infrastructure and marketing will happen every time because the old is revived and brought to show that this is the best radiation. An overall view of a general radiation therapy is only two things. From a distant, that is teletherapy. Pakatla pandrathu brachytherapy. In Greek word, it is called close to the organ. So brachytherapy, we have image assisted and electronic. In teletherapy, we have 3D CRT, that is a 3D conformal radiation. We now do radiation by taking CT scans. So today we have also become very sophisticated. We are not just like that. I remember my father-in-law is a retired general surgeon. So he used to tell me when he used to walk on the rounds, it's pretty old he is. So he'd say, cancer ward, so he was very happy that I took up oncology and I am in radiation oncology because it means it is not mutilating like what no offense meant to human, but it is not mutilating. Radiation is conserving the organ, and nowadays we are into conservation. Whether it is vocal cord cancer, whether it is breast conservation, everywhere we are trying to conserve. So that is the idea behind this multimodality therapy also. We are giving chemotherapy and they are doing a microlaryngeal excision for just the vocal cord tumor, then the radiation is given. So like that, everywhere we try to join hands and try to give a good result to the patient so that patient's voice is conserved, breast is conserved, they do not, there are a lot of psychiatric problems that the patient undergoes. It's a hell a lot of things that they undergo. So this kind of helps, and today it is possible. So why not? And teletherapy, so 3D conformal radiation I was talking about is a conformity. By taking a CT scan, we know where all we have to give the radiation, where all we don't want to give the radiation. Why? Because as I said, earlier age it was just you tap and you open the area and you give radiation to the entire area. Be there an urinary bladder, be there a rectum, everything gets irradiated. But today it is not like that. We are not taking the rectum or the bladder out, it is all there, but we can plan our radiation in such a way to give only to the targeted area. You can avoid the rectum and the bladder, especially in gynae, even in breast. If it is in the left side, you can avoid unnecessary dose to the heart, lung, etc. So a lot of this is the game changer. It is a simple mission. Today it is available across Tamil Nadu in all the government institutes also. It is not only confined to private setup. It is available in all the government centers also. As I am secretary of Association of Radiation Oncologists of India, Tamil Nadu Puducherry chapter, it's my honor duty to mention that it is treatment for cancer is available in nook and corner of Tamil Nadu and Pondicherry. It is just that an oncology setup people have to find and go. So radiation, according to the aim, timing and mode, So aim is again whether you want to cure the patient, is it a curative attempt, is it a palliative attempt, or is it a prophylactic attempt? So it is based on this that we have to take a decision. Sometime post-operatively, adjuvant, that is after the main thing is over, adjuvantly we are giving, or before the main event, before the surgery, we are giving it as neoadjuvant, or concurrently, along with, especially in oral cancers and all, we give chemotherapy along with the radiation. It gives good results. So similarly, we don't know in which area this particular tumor of a person will be it in cervix or endometrium. Everywhere there is a role reversal for radiation and surgery and chemotherapy. The mode, whether it is teletherapy, brachy, intraoperative or stereotactic, all these are available. And this is just to show there is today's change in scenario. I try to put it in one slide so that you don't have to think about it much. The patient is position, which position they are comfortable in. So we make an immobilization device accordingly, and it's called mold making, a mold whatever is made for the patient. Then we acquire data by taking a CT. Then that CT is transferred to the treatment planning system. In that system, we are drawing, we can call it contouring, we say. So we contour the areas that we want to give radiation. After that is done, a target volume we have acquired. What is the volume that we are going to? So, sir, radiation oncologists are also a little bit radiologists in that way. So after that, we get a planning. The planning is then we do the quality assessment of it. A QA is done for it. After the QA is passed, then we go for the treatment delivery. So much of the procedure is there prior to doing radiation, not like olden days now. It is changed. So we have many volumes, a gross target volume, a clinical target volume, and then we do the planning target volume. So each of it is based on what is the macroscopic disease and then what is the uncertainties. Every day, 20 to 25 days and all are there radiation, or sometimes we are giving short courses of radiation also, a week and all. During COVID, a lot of protocols came up for discussion, and some of it which are convincing we have taken up. So in such scenarios, patient setup is extremely important. So we acquire CT on board. When the patient is lying down, we take some images, confirm whether we are doing the right thing. Anyway, if we are doing the wrong thing, the machine will not on. So nothing to be worried. So because unless and all these things are put in the system, it's all programmed. So we don't have to worry about that. So this is how a gross volume is there. Then there is a planning target volume where movement and errors etc. can be, like today the patient might have eaten more, so the everything might be a little different. See, here we are seeing few millimeter difference. Few millimeter difference is what we are targeting and sitting, and patient will eat and come, has got bloating, has got constipation, then we have to do enema, clear the bowel and then proceed. Or if their bladder is full, make sure that they empty the bladder and come. So there are so many issues. So for all that, that is checked, and then this is how we target, this is what we draw. IMRT, IGRT, all these are the types of radiation, just like 3D conformal, which is the basic sophisticated. IGRT, that is gating, that includes the respiratory movement. So when the respiration, there is some movement, the abdomen also there is some movement. All this is gated. So we find out how much is the difference. We teach them, and the patient also gets to know how they should hold. The breath holding techniques are there. We teach them. We spend some time, and then this is done. So speed really matters in today's world, and that is what I meant by telling you that a particular time is the time frame for the treatment for many cancers. So we should make sure that within that biological time we complete the treatment. Now man has become very slow, even the animal has become very slow. It is all the machinery which is very fast. So with time, we have to move with time. So a little sophistication of that is this rapid arc or the volumetric arc therapy we call it, where again unnecessary radiation, if you look at the amount of radiation exposure, it is lesser in the rapid arc compared to the IMRT, which is 1685 and there it is 496 for the same target. So unnecessary exposure of radiation to the normal tissue is also avoided and reduced. So this is for a lung cancer and a breast, that's a chest wall that I have marked, and here how the radiation beams are planned, and this is for a lung cancer, how we are avoiding the heart which is in the middle. So when this way we try to avoid the unnecessary dosage to the heart. So times have changed. We have to become, there can be no compromise on precision. That is the idea. Radiation oncology has reached such heights that today we cannot compromise on precision. And there is no limit to the freedom that it is offering. So this is what I was talking about, the Rapidas. It's a revolutionary. Now we are going a little further on that. The speed by which, what is rapid or what is this volumetric arc therapy is nothing but it is faster. So that is the idea. So the radiation is faster, the arc is faster. The going of the gantry is faster. This is something, again, why should patient be given radiation after surgery and all that? I'm sure our surgeon will tell, but just one picture was there, so I thought I'll put. Positive margin, negative margin, they say. So for the negative margins, might not be any requirement, but for some positive margin we have to do. So how will I acquire some images? Now we fuse MRI films, the PET films, we fuse them to the CT that we are taking, and then we mark the area. So again, more precision. So we do not miss anything. Now with experience we learn in case we miss something. So there is a good and a bad of it. So with experience is what everybody learns. So here we have a MR PET fused image. Now this image is fused along with the CT that we would have taken, and then we plan the radiation. This is for a conserved breast. So it's just to show how we have taken the CT, given this beam if you see, and the red portion is the cardiac area. This is how we are planning the radiation, where there is absolutely very minimal dose to the heart and the lung. There is some 0.5 or so lung involvement will be there, but definitely much lesser. This is to show conventionally how it is and IMRT how it is. When you see in the convention, as I have marked in the red, how much of radiation is going to different beams. These are all images just like that I have lifted, but just to tell you that how when we are giving for 25 days radiation to the breast, it is not the breast alone. We also include the supraclavicular region, that is the nodal regions, axillary region and all. So this is where the expertise of the surgeon lies. So how well he has done the surgery and how less we have to give radiation. So all this burden is on my surgical colleague. So the response of the treatment, this is in case of stereotactic radiation to the liver lesions. We have given a stereotactic radiation to this patient, and the response is scanned. So proton therapy, if I don't talk again, it will be incomplete since I touched radiation. So proton is actually again very precise. It the side effects are reduced, especially indicated in children. when they are having Wilms tumor or other sarcomas, when we radiate, the vertebra is included. So this vertebra we can avoid. What happens is the growth plate gets affected, and the patient, the child when he grows up is stunted growth and other issues are there. Now all that can be negated when you go for proton therapy. Other than that, we don't find much of a benefit in this. It's an old issue, but it's a brachytherapy, as I told, close to the organ. We have intracavitary. For uterine cancer, many a time after post-operatively abdominal hysterectomy is done, then we come to know that that was CA of the uterus. So nodal dissection has to be done. Sometimes we can do laparoscopically nodal dissection. If it is not possible, again radiation can be given, and subsequently post-operatively we can give vault brachytherapy. In cervix case, we do intracavitary. In uterine hysterectomy situation, we do a vault brachytherapy, where the uterus is removed, so there we are giving vault brachytherapy. Other intraluminal and surface mold and all. Intraluminal is for esophageal cancers that we are doing, and surface mold for all these skin cancers and lip cancers and all, we are doing surface mold. It is giving excellent results. During COVID, we had one patient. She had squamous cell carcinoma of the lip phase. For almost 6-7 years, she has not come. She is about 65-70. She has not come out of her house for any function or anything. But during COVID, she came wearing a mask. She was very happy that she doesn't have to worry. So when she came and she showed me this large lesion, we gave her electron therapy. It got cured. She refused to wear the mask again. Even though it was peak of COVID, I was telling her, please wear the mask and go out. That is the kind of conservation that radiation can offer to the patient. When we do surgery to this area, definitely our surgeons will not operate this kind of area, lip and all these areas, they will not touch, because it is definitely give a very bad scar to the patient. But this was a very nice anecdote.
Like the incidence of cancer, did it come down to COVID? Like asthma
No, sir.
really came down to
Sir, incidence, we can't say. Incidence of patient coming to the doctor came down. So we found many of them in advanced stage. When this lockdown opened up, many people came in very bad shape. That first 6-7 months was horrible. I had a lot of very sick patients coming to me. That was very sad. So this is the brachytherapy unit. Post endometrial carcinoma, we can give brachytherapy to the patient, which helps. Vault brachytherapy, that is what we do. We keep an appliance which is very conducive, and it reduces dose to the bladder and the rectum. It's an OP procedure. It's just 1 hour. The whole thing, including planning, everything takes about an hour or 2. Patient comes in, it's an absolute OP procedure. Brachytherapy, like in those days, was different, and today it is like an OP procedure. So it's a very simple thing. I have taken a lot of time. I hope my information was useful. If there are anything that you would like to know, please.
Can there be two different...
Due to mental stress, main cause for cancer, madam?
So definitely stress is the main cause for a whole lot of disease, and yes, for cancer also, sir. Cardiac also, stress is a cause.
But I came across 2 officials, top officials, because of the mental stress, they developed the cancer.
Sir, I have noticed in my OP, there has always been, you know how dramatic our people are when they come. The children will come inside and say, Madam, நீங்க அம்மா கிட்ட எதுவும் சொல்லிடாதீங்க, அவங்களுக்கு கேன்சர் இருக்குன்னு நாங்க எதுவும் சொல்லல. So எல்லாமே தெரிஞ்சிட்டு they come inside and then they will ask, நீங்க வந்து அவங்களுக்கு எப்படி சொல்லணுமோ சொல்லிடுங்க மேடம், ஆனா கேன்சர் இருக்குன்னு மட்டும் சொல்லாதீங்க. Then ஏன்பா ஏன் அப்படி அப்படின்னா, அங்க வந்தா ட்ரீட்மெண்ட்க்கு வந்தா கண்டிப்பா பார்த்தா தெரியும் தானே அப்படின்னா, இல்ல மேடம் இப்பதான் ஒரு 6 மாசம் முன்னாடி அப்பா இறந்தாரு. So there is a stress factor. This is not in one case. So many cases. Just to rewind a little in time, the patient will break down. They will give this history. Something would have happened, and either a child or a daughter or a divorce, all these things. So multiple factors. We are staying in a society where stress will definitely get to us in one way or the other, and probably yes, as you are saying, mental stress is a big pointer for cancer. So I have been noticing that. I've been noting it down. I don't know, someday I hope I can get some good people to also collaborate with me and put this paper out, because stress is a very important cause for cancer. It contributes.
Can there be two different cancers in the same person?
Yes.
Huh? Is there any genetic predisposition like that?
Yes, ma'am. There is.
What are the cancers that are radio resistant?
Sir, melanoma,
Radio resistant.
it doesn't really help. Other than that, even lymphomas, age old before chemotherapy was there, radiation was what?
I am Dr. Muniyappan, surgeon, and also Dean of 5th Medical College now. I was in Cancer Institute from 1984 to 87 with Dr. Santa Madam. Dr. Santa Madam told in an interview, we have to highlight that statement in this forum. I was a pet of Dr. Santa till then. She told on an interview, what is your ambition and dream? She told, my ambition and dream is there should not be any cancer hospital in the world. That means there should not be any cancer patients in the world. That statement I should highlight in this. I was the eyewitness at that time of interview. I was with her. Then I am congratulating your presentation is very, very nice and informative. Then I was very happy to hear that you are interested in prevention of cancer.
Yes, sir.
That is the ambition of Dr. Santa. Prevention is better than cure.
Yes.
That is another statement. You might have heard nowadays the CS cervix is increased in India up to 40%. It is increased now. That is the statistics. Now the Union government decided to immunize all the school-going children from 9 to 14. They advised vaccination for CS cervix. Now most of the schools started to vaccinate the children, female children, from the age of 9 to 14. I want to give you a suggestion regarding this vital situation going on in India.
Sir, I am from Cancer Institute, Adyar. I was working and was assisting Dr. Shanta for about 10 years. And I was also an Atlas medical officer. That's how I joined there. After that, did my diploma and my MD there. I thought my life was there. But somewhere down the line, Madam was not involved in many things. So I moved out. And her thoughts are probably what is ingrained into all of us students of that time. So preventive oncology is something which all of us always stress upon, and we try and give as much as possible awareness talks at any point, be it at IMAs or be it for the common people. And I'm also happy to share with this august audience that Thursday I received an award for this talk and doing a lot of stuff. Only thing I was for ahead of Women's Day, they gave me this award, and it is called as Realistic Award 2023. And I was an odd man out there because all the others were models, actresses, IRS officers, and some weightlifting person and all that. And yes, I found what did I do that they have called me here. But it was a wonderful experience to note that people are interested to change their lifestyle and become conscious. A healthy country definitely is what we need. So unless and until our academics and health are free, we will not have a bright country. So with these few words, I thank you all for this opportunity. I thank Insta Hospital, and I thank IMA, the Independent Medical Practitioners Association, as well as IMA Chennai Metro for this opportunity. Thank you so much.
Congratulations, Dr. Sarita, for a beautiful presentation, especially about the radiation therapy. Although it is to a level best, you have presented it. It's a wide topic, I know.